she's from ACERT, and she has her partners from the Manchester Police Department. Would like to step up and let us know about, we're very excited to learn about this.
So, thanks for having us. I'm Lara Quiroga. I'm based out of the Manchester Community Health Center. As I mentioned, was directing project launch of federal SAMHSA grant for the last 5 years that sort of had two pieces. One was around building infrastructure at the state level and helping to coordinate the systems that children birth through 8 and their families access. And then there was also a local level component. The state chose Manchester to do that similar kind of policy infrastructure system coordination work for children birth through 8 and their families, as well as some direct services. So I'm gonna skip over that part, because if you really wanna know, just come talk to me and I can give you an info sheet or whatever. But one of the big things that we were charged with was collaborations with other agencies. And so we'll get more into the collaboration piece in a few minutes. But first we wanna talk about, we sort of wanna get us on the same page. So actually, before we get on the same page, do you wanna say anything else about who you are? Doesn't sound like it. Okay, so we're gonna go right into.
Do you want me to be the clicker?
Sure, if you want. So I'm just gonna get us all on the same page in the context of trauma and how children grow and develop. Before we get into the weeds, it's important to frame the issue that we're currently facing. And so it's hard to sort of see that picture. I know it's a small screen, but I'm happy to send the PowerPoint to you, Celeste, afterwards, and you can share it with people here and anyone who wasn't able to make it, that's fine. So you sort of see in this picture on the left-hand side is this sort of Norman Rockwellian picture with two parents really, lovingly looking over, their child. They're like this quintessential American family, right? In stark contrast, we see this young child not being, directly sort of abused or in the same room, but clearly what looks like her parents arguing. So she has this exposure. And what we know is that for young children, that's really traumatic. And that exposure causes trauma. And so we need to start shifting the conversation from, this is not drama in people's lives. This is actually trauma. It's not what's wrong with you. It's what happened to you. If you're looking for a good resource on a lot of the more science about this, the Harvard Center on the Developing Child is a wonderful resource. They have an awesome website that has articles and multimedia presentations and videos that I'm sure will be interesting and answer any question you might have about this. But essentially their body of research has demonstrated that the healthy development of children provides a strong foundation for healthy and competent adulthood, responsible citizenship, economic productivity, strong communities, and a sustainable society. So what develops in children? In terms of the brain architecture develops certainly in utero, but from the moment of birth, it's just this exponential growth that happens. And the way that it forms is like a house. There's a foundation that is built. Really simple skills come first, and complex skills build on those. So a really simple example is it's important to learn the ABCs before you learn how to read. It's gonna make reading a lot easier. So we want that strong foundation because it improves the odds for positive outcomes later on in life. Conversely, a weak foundation increases the odds for problems later in life. So how does that brain architecture form? It forms through relationships, and what the Harvard Center typically refers to as serve and return relationships, that interactive, communicative relationship between a caring adult and a child. As we go through some of this, I'm probably just gonna say parent, but please know that I know it's not always a parent, it's a foster parent, it's a grandparent, or some other relative. So children are looking looking for that connection. They're reaching out for connections and to communicate with adults, and adults need to reciprocate, so that back and forth is really important. That's why it's called serve and return. Even with a small infant, right, if you've ever held a baby and they look at you, your eyes connect, they smile, you smile back, they make a noise, and you, right back at them. That is that serve and return, that building of trust and the relationship. And those interactions wire the brain with the connections that are needed for healthy development. So what derails development? That strong foundation doesn't always happen. And toxic stress is often the cause of that. So mild and short-lived stress is normal and good and important for development. So getting an immunization, for example, can be really stressful for a child, but it's short-lived. Their parent is with them. They can help to soothe them. I always give the example, like, I used to freak out about it, but like I'd get the shot and my mom was there and she'd hug me and we'd go get a caramel sundae from McDonald's afterwards. Everything was okay. I made it through. It was a positive interaction. But toxic stress is prolonged stress, pervasive stress that can actually weaken the brain's architecture. And so things like abuse, neglect, and exposure to violence can cause toxic stress responses in the brain. They have lifelong consequences for health, learning, and behavior. So your brain produces this chemical called cortisol, and it literally damages physiologically your brain. And it causes all sorts of biological responses. So like when you are in a really stressful situation, what does your body do? Anyone can answer.
Your heart beats faster.
Your heart beats faster. You get into this fight or flight mode, right? Increased heart rate, increased respiratory rate, and you're going to run or you're going to put up a fight. There's a great example if you've ever seen TED Talks. They're on YouTube. There's one by this woman named, she's a doctor, Nadine Burke-Harris out of San Francisco. She gives about a 15-minute talk about how understanding toxic stress really changed her practice, and she gives an example of what she calls a bear in the classroom. So, our bodies were made, if we were in the woods and we came across a bear, right, we would fight or we would run. That's how we're just programmed, right? Basic instincts in our brain. Now, that's great if you run into a bear in the woods. But if you're in your day-to-day life constantly living in these toxic stress situations like abuse, neglect, exposure to violence, your brain is being wired to always be in that fight or flight mode. So when you go in the classroom, your response system has essentially been trained to always be in that fight or flight mode. And so we see kids that are looking for fights, running out of the classroom, avoiding contact with other people, or really being aggressive. So they're always sort of in that mode. So check that TED Talk out if you want. But essentially, our toxic stress wires our brain to always be in this high state of alert. So this is impossible to see up there, but I gave you a handout that at the top says the truth about ACEs. In 1998, Kaiser Permanente, a researcher from Kaiser Permanente and a researcher from the CDC, released their study about what they call adverse childhood experiences. The adverse childhood experiences are listed on the bottom left-hand side of that page, but they generally include abuse, neglect, and broadly household dysfunction. So things like maternal depression, parental incarceration, divorce, substance abuse in the home, those kinds of things. And what they found was that the more adverse childhood experiences you have, the more likely you are to experience poor behavioral, physical, and mental health problems later on in life. And more recently, there's been research into not only adverse childhood experiences, but adverse community experiences that cause toxic stress environments and reactions that children are living in. So things like poverty, lack of opportunity, economic mobility, poor housing quality, violence in the community. So there's not only the individual sort of household-based or family-based experience that children have, but their community environment is also this sort of adverse experience for them. So an example that I often give, and I literally know like 2 things about Raymond and their people, and I only knew one until yesterday. That Matt is from Raymond, and like I know someone else who is, I think she's still a school nurse in Raymond. Like that's it. So I'm going to give you an example about Manchester, but it may be the case that you can think of a child such as this or an area in your community such as this. So in Manchester, we have Center City. And in terms of census tract, it is, you see a lot of these adverse community environments. Extremely poor. Beach Street School is in that neighborhood. They have nearly 100% of their kids on free and reduced meals. And of those kids, 90% of them are living at 50% of the federal poverty or less. They're poor. And so let's imagine a 6-year-old from Beach Street. He's living in an impoverished neighborhood. There's one ACE. His dad was just arrested for domestic violence against his mother. There's ACE number 2. Dad went to jail, ACE number 3. Because mom now is responsible for the household and figuring out the finances, the childcare, all of that, she is depressed, ACE number 4. To deal with her depression, she started using alcohol, ACE number 5. And because she's using alcohol, she's neglecting her child. We just hit 6 ACEs in no time at all. I'm going to come back to that example in a second, but you can see how quickly we can get to that point. Next slide. All right, this one is really hard to say. But on the left-hand side is sort of theoretically how we can get there, right? We have adverse childhood experiences. They can lead to social, emotional, and cognitive impairment. That impairment can lead to the adoption of health risk behaviors like trying drugs, early sexual activity. That can lead to disease, disability, and other kinds of social problems, and eventually an early death. So a really concrete example could be that you could experience sexual abuse as a child, you become depressed, to deal with it you start overeating, you end up getting diabetes, and you die of an early death. Okay, next slide. Additional research has shown that children with 6 or 7 adverse childhood experiences have a 90 to 100% chance of being diagnosed with a developmental delay. This has serious implications for our family-centered early supports and services and our school districts in terms of special education. And additional research around the prevalence of illicit drug use has come out. So a child with 5 or more ACEs is about 10% more likely to use an illicit drug by age 14. Same number of ACEs, you're about 40% more likely to use an illicit drug over the course of your lifetime. So if you think about what's happening now in our state and around the nation in terms of the opioid crisis, if we don't start dealing with these adverse childhood experiences now, we're going to have a way worse problem given the increased risk for illicit drug use. So think about that, right? That 6-year-old Beach Street School's kid. He's at 6 ACEs. We're looking at developmental delays, and we're looking at increased risk for using illicit drugs. There's another body of research that says a male child with 6 ACEs is 4,600% more likely to use an IV drug. Nothing increases 4,600%. That's huge. Okay, so doom and gloom. We're gonna lift us up out of that. How can children overcome? It's back to that serve-and-turn relationships. They need caring adults in these responsive relationships in order to change the way the brain is developing, to change the architecture of the brain, and to get to mitigate the impacts that toxic stress has had. So how do we do it? We need to, treatment is important, and I'm not gonna deny that. I know that that is very real in our communities right now, but we cannot forget about prevention and wellness promotion. So we need to think about the highly specialized interventions with families as soon as possible for children to decrease the impacts of that toxic stress. We need to always be talking about developmental and behavioral health when we're talking about children. We want to make sure that there are safe and supportive environments and programs in which children can develop and learn. And we want to, again, mitigate toxic stress and other kinds of health disparities by creating a shared vision and plan among the community in the various sectors that children and families access. So some examples of that, again, sort of like home visiting to pregnant women and families with newborns is a highly specialized intervention that has a strong evidence base and is highly effective. Parenting training programs, intimate partner violence prevention, social support for parents, parent support programs for teens and teen pregnancy prevention programs, mental illness and substance use treatment, high quality child care, and then sufficient income support for lower income families. Those are all really specific examples of highly specialized interventions that are really helpful in mitigating toxic stress. So we're gonna shift from sort of like getting us all on the same page and understand some of the why behind we're doing this to actually talking about what we decided to do in Manchester. Pete, take it away.
Okay.
I can get computer today.
So in 2014, that's when the opioid epidemic really came to light in Manchester. We were really like punched in the face with it. It was tying up a ton of resources. We were going to calls nonstop for ODs, probably 10 to 12 a day. It was bad. So in 2014, Lieutenant, retired now, Nicole Ledoux, Lieutenant Paul Thompson, they were both sergeants in our unit. So Paul Thompson was the domestic and sexual violence sergeant, Nicole was the juvenile sergeant, and their boss, Sean Layton, was lieutenant at the time. They were all sitting around in the office and they were discussing these crazy calls, these OD calls, where a 5-year-old is calling 911 because their mom's ODing on the floor. They don't know what to do. Mom's unresponsive, or the 4-year-old. The officers get there and they find the 4-year-old drawing on the deceased mother, or the 12-year-old doing homework where the mom falls out and crashes onto the kitchen table where he's doing his homework, overdosing, falls out of the bathroom and is overdosing on the kitchen table. Those are just like a couple of instances, but that was happening like every day, multiple times a day. So they're sitting around, they're like, what can we do? What can, this is a huge issue. What can we do? So they had actually gone to the AG's conference on sexual and domestic violence, and they had heard about these things called ACEs, which is the Adverse Childhood Experience. Now, I've been a cop since 2000. Matt's been a cop, same? Yeah. Since 2000. And we can tell you, from the first week of being a cop, you walk into these places, into these homes, and you're seeing kids that are dealing and living in these toxic stress situations. So toxic stress sounds good, like the slide up there, but you have to understand what that actually is. That's little kids who are growing up in these homes where mom and dad, or boyfriend, mom and her boyfriend, or dad and his girlfriend are fighting constantly. A good day is when you get into a verbal screaming match. That's a good day. But the normal day is, somebody's getting hit, somebody's getting beat up. They're in constant fear for either their parent or for themselves because they're being abused. If not physically, then definitely probably emotionally, sexually assaulted. All those ACEs that we were talking about, they're living in that all the time. So their brain is constantly in that fight or flight, and they're constantly in that mode. And it makes absolute sense as a cop. We just never knew what to call it, adverse childhood experience, you know. We would go into these homes, we'd see it, we'd be like, walk out, and we'd be like, man, you know, we're gonna be dealing with that kid in 5 years, or 10 years, you know, we're gonna be locking him up, no doubt about it, you know. Or, you know, walking out and being like, man, you know, those kids don't have a chance in hell of, you know, being a successful adult. So they go to this class, they find out about these ACEs and what that is, and it makes absolute perfect sense to them. So then we start looking into the amount of calls that we're going to. So we looked at, in 2014, more than 400 kids were exposed to domestic violence. So those are calls for service were going on, and there's kids, you know, present for these horrific incidents. 30 children were victims of sexual assault by another juvenile. In both of these cases, there's nobody helping those kids. You know, we have all these plans and all these programs set up for, you know, I'm just gonna say woman in this case, because that's generally the majority of the situation, but, you know, the woman who's beaten by her husband, you know, we have DV pamphlets, we have the YWCA, which is our service provider in Manchester, who are willing to help them. There are advocates in place to work with them to get restraining orders. There is all this stuff, you know, available to them. There's nothing for the kids. There's nothing to address the kids that are living in those homes. Same thing with kids that are victims of crimes from another kid. There's no advocate for them. If a kid is a victim of a crime with an adult, the Superior Court, Hillsborough County, we have advocates there. The advocates are holding those kids' hands every step of the way. There are no juvenile court advocates. There are no advocates for kids if there is a crime committed against them by another juvenile. There's nothing. So these are all problems that we have, right? So there's no advocacy for either, and we're saying this is an issue. What are we going to do about it? We need to bring some people to the table and figure it out. So what we did is we got together with some of our partners. We work very closely with the YWCA. We started working very closely with Lara from Project Launch, the Manchester Community Health Center, the Mental Health Center of Greater Manchester, Child Family Services. We're bringing all these people to the table and trying to figure out what we can do to address this issue. And the main thing we came up with was to create this release form. All right, so the initial plan was that patrol officers would be given yet another form that they would be responsible for to bring to these horrific calls, and to, you know, document that they addressed this form, and that they are going to talk to the parents about the ACERT program, which is this release form that we want to get the parents to sign, which gives us the authorization to take the police report, send it to the service provider, and then have that service provider call the family and make an appointment for their kid to go in and get some help. Because these people, they are in crisis themselves, right? It's not that they don't care about their kids. It's not that, I mean, some instances I'd probably say they don't, but generally they are dealing with their own crisis. And so their kid, and what they, you know, they're saying, you know, well, you know, Susie didn't hear the fight last night. She was sleeping, or, you know, Johnny wasn't you know, here for the assault when my husband punched me in the face. You know, they're okay. And you and I both know that, you know, kids hear and see everything. My daughter is like it's crazy. Like, radar is on, and she's always got an ear to you know, listen to what's going on in the house. My son's the same. Well, actually, he's not quite as.
When you want them to listen, they don't. But when you don't want them to listen,
yeah, you can't peel him away from the video game system. But kids are always hearing this stuff, and the parents, a lot of times, for whatever reason, they don't want to recognize that their kids are hearing it, because it's embarrassing, and, you know, nobody would want their kids to actually hear that. So, you know, they're fooling themselves by saying, you know, they didn't really hear what happened or what took place. So what this does is it gives us the chance to go in there. We take care of the situation. If somebody needs to get locked up, they get locked up. But we write our police report, we talk to the parent, the one that's staying, we tell them about the program, we try to educate them a little bit as far, because we're police, we're not social workers, we're not scientists, this isn't our realm. But we know that kids are being affected by these issues. So we're trying to let them know, hey, your kid's being affected by this stuff. We're just trying to get them help. If you sign this release form, we will get in touch with the service providers that can reach out and help your kids, counselors, things like that, therapy for your kids, and we can move on with life, and hopefully your kid will be able to acclimate themselves and be able to move forward from this. Yeah.
Yes. So, so we did this sort of like initial work without necessarily taking a particular approach to it. Like, we just wanted to help the children and families. And we, again, talking with partners, really felt like the release form would be the way to do it and sort of make it easier for families to get engaged, sort of taking the onus off of them, and rather than giving them a brochure and crossing our fingers that they would make a call, we could be a little more active and do a little, facilitate that process a little bit better. So as we continue to work and see how the release form was panning out, and we continue to sort of meet and talk about what we wanted to happen, we started to develop this theory of change, which really is that we have some really critical levers in our community, and I imagine the same is the case here in Raymond. So we have really strong agency partnerships. Minimally, we have people in various agencies that know each other well and call each other often about the families they're trying to serve. But oftentimes there's more formal, maybe agreements between organizations. But nonetheless, there are partnerships among the agencies. And now we have systems working together. It's not just the social service sector or the medical sector. All of these sectors, including law enforcement, are working together. We identified that professional development, in some way, workforce development was an important piece of this, particularly in terms of understanding adverse childhood experiences and trauma-informed services. And so we thought, in terms of strategy, what we could do is respond to families in crisis and link families to services and opportunities available in the community. By implementing those strategies, we would be building protective factors in families, which particularly those related to parental resilience and helping parents know where to go for concrete support in times of need. And if we could build those protective factors, in the end, we would have more strong and resilient families, and we'd be mitigating the effects of adverse childhood experiences. So that was kind of the lens we used to move forward.
So these are the people that we partnered with. These are all the people that are available on our referral that we can refer kids to. So we have the Manchester Community Health Center, we have the YWCA, the Mental Health Center of Greater Manchester, Child and Family Services. We've got the Catholic schools in Manchester on board, and we also got CREATE. So CREATE is like a expressive art therapy. It's probably our most popular service. That it's art therapy. It's not. It just, for whatever reason, I don't know if the kids just like it better, or it doesn't sound as, I don't know, Sigmund Freudy type of help. So that's definitely our most popular. And then we brought on Upreach, which is a unmounted equine therapy. They are probably our most enthusiastic partners. They love the program. They have gone out and sought their own funding to assist with their funding for the kids to be able to go to these programs. It's for ages like 7 to 13, and then they're expanding it from, I think the next class is going to be 7 to 18. But it's, the kids sign up for it, they go, their parents go with them while the kids are doing the horse therapy part of it. The parents are having parenting classes. At the end of it, they come together, they have dinner, which is provided there by the Upreach people, and it's like a 7 or 8 week program that they go through. Yeah, that's pretty much it. Those are our partners. This is our actual referral, or our release of information. You guys probably can't see it from there, but we just put the kid's name, date of birth, case number up here, and it just says, I authorize the Manchester Police Department and the AmeriCorps Victim Assistance Program to release verbal and/or written information about the above case for the purpose of treatment and coordination of services for my child. And then it lists the different partners that we were partnered with. On the back of this page, which we don't have in this PowerPoint, it lists what each partner can provide. And then permission for release of information will continue for the duration of the involvement of the client with any of these agencies or until permission is withdrawn. Permission may be withdrawn at any time. So this is a one-way information flow. We don't get anything back from them due to HIPAA laws and things like that. So this just, again, I've already said it before, but it allows us to take that police report and give it to the service provider, and then they're able to reach out to the family and arrange for services for their kid. So that's how the whole program started. That's how we were initially doing it. This is kind of the nuts and bolts of how we made it happen. The patrol officers had the releases in their patrol bag. They would go to these calls, they would recognize that if a kid was there, they would pull out the referral, they'd talk to the family, try to get them to sign it. If they don't want to sign it, which happened a lot, they would note it in their report. They would then, the report would be submitted. The next day, probably a very important part of this, we ended up getting a AmeriCorps victim service advocate to come to the police station full-time, and she kind of managed the day-to-day operations of the ACERT program by going through police reports, calling families, trying to send out letters, trying to get people involved in the program. And she was the one that was taking the police report, sending it to the service providers, and doing the kind of soft handoff with them, and then letting them go ahead and contact the family. That's what her job was. It wasn't working. It was successful in that she started in October. So the program started in October 2015. From October 2015 through June of 2016, we only had 51 referrals get signed, and so we were only able to help 51 kids. Which you're going to see, again, that's 51 kids that weren't getting services prior to, but we weren't very happy with those numbers because we're going to a lot more calls than 51 where kids are present. So we looked into it, and we applied for funding from the H&H Foundation to have an actual response team. What we wanted to do was respond in real time out to the houses. Once patrol had got there and had kind of taken care of the situation, if somebody got locked up and they got locked up, they were out of the area, our response team would show up and talk to the family and try to get them to sign this ACERT referral. That worked a little bit. It wasn't that successful, but that team was made up of a police officer, a advocate from the YWCA, our service provider for domestic violence, and a mental health worker. The mental health worker's job was to talk about the program, talk about toxic stress, talk about ACEs, and try to educate the family on what this is doing to their kids, and try to get them to sign the release. The Y advocate was there to deal with any domestic violence issues, because a lot of times we're responding in real time, so somebody might have just got locked up, they just went through some domestic violence crime, and they're there for them to kind of talk to them about their options and things that they can do, and how the YWCA can help them, and things like that. And then the police officer is there for safety, security, and kind of, assist in all of that as well. What am I missing? So to do this, we realized we needed to train these these people, train the response team to go out. You're only as good as your training, and so if our response team didn't really understand ACEs and didn't really know what they were talking about, obviously it's not going to sell your program very well. So we did some training. Lara and Jessica Chagru, she's not with us today, but she's one of our partners. She's the CEO of the YWCA. They taught us about ACEs, what tacit stress does, and a lot of these officers, well, all of them, it makes absolute perfect sense to us. We just never knew what it was called. And a lot of the officers, they're going out and they're seeing this stuff and it's affecting them as well. And now to, be able to put a name to it and understand, how you're feeling after you go to some of these calls and things like that, it was an absolute benefit for them as well. So yeah, I kind of talked about this already. Team composition, you got the child advocate, that's the AVAP. So for us, I don't know if you guys are familiar with AmeriCorps. You can apply for an AmeriCorps advocate. It's usually somebody like fresh out, not always, but usually fresh out of college. They're looking to build their resume up, get some experience. It is an extremely cheap way to get a full-time person. So for us, I think the payout for the Manchester Police is $7,000 for a full-time AVAP that you would have for a whole year. It runs from September through the end of August, so a full year. And I think AmeriCorps matches the $7,000. So yeah, I mean they're living like under the poverty line. They're only making like 14 grand a year. But generally, a lot of times it's kids that just got their college diploma and they're still living with their families, living at home, and they're just trying to build their resume up and get some experience. I will say almost all of our, just a little plug for AmeriCorps, all of our advocates get good jobs when they get out. It's just one of our selling points. But that's one way if you're trying to think of funding or trying to think of, of ways to man the operation. AmeriCorps is a pretty cheap way to go about doing it. So then this is the rest of the team: the Manchester police officer, the crisis services advocate, and then the community health worker. Do you want to talk about this one? Or?
Sure. Yeah.
Ram Pride, right? I can't use that enough. Lara talks about how she just found out I was from Raymond, but we've known each other for a while. I just, when she says, hey, we got a presentation in Raymond, do you want to help? There's only one answer to that question when you're from Raymond. Yes, I do. Raymond High, Savannah, right? Senior? Good job. Not good job being a senior. You have to do that by law, but good job being part of groups like this. It's awesome to see. So I'm going to go a little bit through the workflow and really how this kind of like boots on the ground type stuff, more maybe for the chief, and how the program actually works when we go out and we actually implement it. So on the right side, Pete was just talking about, that's kind of like the initial how we started. We would have this 3-person team, the police officer. The team would just kind of meet. The 3 of us would go and we'd grab a car and we'd just kind of drive around and listen to the radio and wait for a call to come in, right? But like in any other aspect of police work, how does that work? When you put 3 groups of a team together to go and get a robbery suspect because you're getting hammered with robberies, how many robberies do you have? You have 0, but then you have 10 on Christmas Eve when nobody's working. So we would find ourselves really just driving around, like talking about what you did for the day, and this is really like a program that morphs as we go, and we met, we came back together, and we said, hey, we're kind of wasting our time because what we're doing is we're driving around and we have this great idea to help kids, but we might go to one call, and like Pete said, you go to a domestic where there's a couple of kids and you've got an officer saying, hey, here's all this info, but here's just one more thing. Are you interested in services for your kid? And the parent or the victim was going, well, this is too much. So we kind of revamped it. We came back together and we said, let's put something together where we can have this AVAP, this person, this can sit at a desk and she can look through all these reports and see what's come in over the past few days that we can go out and respond to kind of after the dust is settled. So on the left, you'll see we have our own little roll call where we come together. We have an ACERT bag. It's just a backpack. It's got all the reports in a folder that we're interested in for that time frame. I don't think you went over the timing of it. We currently do it on Wednesdays from 5 to 9 and on Thursdays from 5 to 9. And I think we'll probably go over that a little bit after. But That was the timing that we found. That's changed a little bit as well. Initially, we were doing Saturday nights, and that wasn't ideal. So we found that Wednesdays from 5 to 9 p.m. and Thursdays from 5 to 9 p.m. are a great time where we can go and respond to these things that have happened a couple of days earlier, and get the most bang for our buck, because we can virtually put 10 different calls for service that have happened over the past few days into this bag, and respond to 10 different families. So we get together, we review all the reports, we all get on the same page as far as what the needs are, what the addresses are, what the crime, what the call was, the call for service, the crime, whether it was an overdose, a domestic, and then we respond out to the address, and we meet with the family. We, like Pete said, the police, we're just kind of there as security. We kind of just get our foot in the door, knock on the door, we introduce ourselves, and then we kind of turn it over to the advocates to explain what the programs are available to them. Another thing that we started doing is actually picking up the phone. We'll grab the police report, and we'll, you know, a lot of times you go, you knock on the door, somebody might look out the window, they're on the 3rd floor, they see 3 people walking up to their house, and they're dressed like this, or they're like Pete, they have a jacket on, and they might think we're DCYF, and they're not gonna open the door. They might just think, oh, here's the police again, I don't wanna talk to them. But if we pick up the phone and make a phone call to these victims and say, hey, I'm at Larochelle, I work for the police department, I'm not following up on the domestic you just had with your boyfriend or your girlfriend, husband or wife the other day. What I'm here to talk to you about is your child, and we have a team that we put together, and we can offer your child resources. So if you don't mind, we'll stop by at 5:30, and I can run you through that. We have a form you can look at, and kind of just it opens the door for us to get in, and kind of knocks down the barrier that this person may have built up about who's there to talk to them. I cover everything there? So that's really it.
And the process stays the same, where that release goes to the advocate, she connects with the agency, right, and the agency makes the call.
Yeah, so really with that release, what we're allowing to happen is we're saying to the victim or the parent, we have your police report here, and we'd like you to sign off to let these other agencies also view this situation and offer you services. We had some, you know, in the early stages, when we were trying to do, if you look at that right side where we go to real-time calls, we were finding ourselves getting bogged down with, you know, if you do find yourself responding to a real-time domestic, and we just keep using domestics because it's the bulk of our work, whether it was a domestic or an overdose, we get there, and it's great that we're there and we're real-time, but that's it. That's all we have for that night, and we're not responding to the other 6 or 8 that we could effectively help. So we do still go real time if we're working and there's a domestic and the team's out. We'll go over there and pop in and say, hey, we're here for you if you need us, but we'll also revisit that when the team's out again. And we try not to really get bogged down with those real time calls, just because it's not as efficient.
So like on a lot of those, so every time, so when a patrol officer goes out and gives the referral to them and they say, no, we're not interested, regardless of whatever they say, our advocate is calling them again. We're touching base with them again. Because at that time when they say no, they're in that crisis. They're not even hearing anything about the program. You know, they're just, it's like Charlie Brown's teacher. All they want is us to leave. Just get the police out of my house, because and a lot of times, you know, if somebody got locked up, they're dealing with a whole new set of issues now. Maybe that person that got locked up was supposed to go to work tomorrow, or they're the major breadwinner in the house, and now they got locked up. They're not going to show up for the job. They're going to get fired, and this family doesn't have money to pay the bills. There's a lot going on in their heads when you put cuffs on somebody and take their loved one out of the house. So this ACERT referral release form is extremely minor. It's like the last thing on the list that they want to deal with. So regardless of whatever they say when the patrol officer gives it to them, we always follow up. We've had a lot more success with the teams going out, and I'll show you that now. When the teams go out, so from October, you guys can't see this, from October 2015 to June 2016, we had 51 releases signed. From July 2016, when the team started going out, through August 2017, that was just like one AVAP, so we're doing it through AVAP years. We had 346 signed, okay? And then from September 2017 through July of 2018, we had 400 signed. So we've had a total of 797 kids get referred for services that otherwise wouldn't have.
Through July, so it's
Through past July. So we don't have current stats for August and September and half of October. So number of families to sign the releases, total of 427. The reason that's different is some families obviously have more kids than just one. Number of children not referred, so families that said no, we're all set, 284 total.
Sometimes they're not interested, sometimes their child might already be in services, so
Yeah.
the reasons vary.
So grand total of kids contacted by the program are 1,081. Grand total of families contacted, 711. Our types of calls, vast majority of our calls where we're coming into contact with families is domestics with crime. Domestics without crime is 86. Missing juveniles, 6. Overdoses, 23. Juvenile calls for service, 23. Sexual assaults, 33. And there's just so many there's a plethora of other calls. We just lump them into other, and it's 92 of them.
There's SWAT raids, suicide attempts, and it runs the gamut. And the number with domestics, even though, certainly it's a focus of the unit that they work in, but it's also the highest volume call they get in Manchester is that call for service around domestic incidents that may or may not involve a crime, but it's the highest. So I want to, what time do you want us to end? 10:25, is that what I saw on the agenda? All right, I want to make sure that we leave time for questions. Yeah. So I'm assuming, the benefits of this collaboration have been obvious, right? We've had contact with more than 1,000 children. Over 800 have been referred. When we started out, it was about 1 in 5 children that were actually following through with the whatever agency it was, their intake process, and actually accessing services, and that's improved 1 to 4. We meet quarterly with with our partners to talk about what's working and what they're seeing. So we don't get, as Pete mentioned, we don't get specific information about families or children back, but we get some sort of aggregate data. For example, how many actually followed through with intake and are accessing services. So that number is improving. The agencies it's helping them to think about what is our intake process, what do we have to do, what could we change that would make it a little less onerous for families. So we're looking at a lot of efficiencies. We're identifying and implementing services that it seems like families are needing or they're saying they're needing. A great example is Create, who had their sort of the expressive arts therapy that Pete mentioned, but parents were so interested in going there, and they weren't equipped to meet that volume. So they said, you know what, we're going to start doing groups for these kids. So now they have group sessions rather than just individual sessions. So service providers are also thinking about how they're doing things to accommodate the needs that they're seeing and make sure that we have the capacity to meet the need. Our relationship has only gotten stronger in terms of not only the core agencies of the health center, the YW, and the police department, but all of our service partners too. They really are getting so good at talking to each other at an agency level. It's really awesome to see. And we've created this shared vision of how we want things to change for children in our community, which is probably, right up there, the most important thing. So in terms of replication, we worked with Worcester. My understanding is they launched their team in the spring. Keene did some initial work. They were looking at their domestic violence numbers in both Keene and Swansea, so they were trying to see if they could take a regional approach and loop in the county sheriff's department. That work sort of stalled when their chief passed away, I think around 2 Christmases ago. But they're starting back up, and there's also been changes in other leadership in that area for providers, so they're trying to get that back up. Carroll County is talking about it and thinking about how they can loop in state police because they have such a lower population, bigger geographic area. And Concord right now is in the process of designing their team. So they have a core team established. They know who is going to be the lead, fiscal agent, and then they're identifying the other partners. 2 years ago, not quite about a year and a half ago, we actually had a 16 or 17 person delegation from Wales come and learn about this work, which was pretty cool. So, what worked, we always talk about this collective impact model. Like, let's get together, what's our shared vision? Like, what do we want to see happen? Let's figure that out. Then we can figure out, like, the details and what's going to work for our community. But what do we want to see happen? Those relationships are key. I really can't stress it enough. It wouldn't work if we didn't trust each other and communicate often about the work that we're doing. And frankly, funders are attracted to innovative practices and systemic approaches, right? They don't just want to fund like one provider or one particular service. We're seeing that sort of across the board. They really want to look at how are we improving the system and what can they fund in terms of the system. And so I don't know if we specifically mentioned it, but the H&H Healthy New Hampshire Foundation, they used to be called Healthy New Hampshire, now they just go by H&H Foundation, was our funder for the $50,000 a year for 3 years. And so some interesting information is that they are actually, their board, I think they've made the decision, they were minimally really close to making the decision that they would look to fund ACERT teams outside of their regular funding cycles, which is great because those are only $30,000 for 1 year. So there's an opportunity there. Did I put some of the funny stuff on the next slide? Not quite. We're also, in the state opioid response application that was submitted to SAMHSA, right, we're getting, 22 or 23 million a year for the next 2 years from the federal government. What they proposed in there and what is starting to go out from the state in RFPs is all the treatment and prevention and such options, right? And people are gonna have to bid. But one of them, specifically around prevention, $700,000 a year for the next 2 years, is available to stand up things like ACERT. They specifically cited ACERT as an example twice in that application. So that's just sort of food for thought as you're thinking about whether you might want to do something like this, that there is funding that will be available for this. So our next steps, we're looking to extend ACERT to our fire department and the ambulance service. We use AMR in case I use that acronym. For a couple reasons, the fire department sometimes go to calls that the police don't respond to. So for example, if there's a robbery in progress and someone's overdosing, the police may not get to that, it's a non-fatal overdose, right? They might, the fire and AMR can take care of that, but it may actually be the case that a kiddo was there. So we want to give the fire department and ambulance an opportunity to connect children that they see to services. And also we have safe stations, which you may have heard about, where there's several fire stations in the city that anyone can walk up to if they are seeking substance use disorder treatment. And what they have shared with us is that it's not just individuals that are walking into the fire stations, it's families. And maybe 1 or 2 adults is seeking treatment, but they have a lot of questions about what about my kids. So we want to make sure that we can help them as well. We want to train all of our first responders in trauma-informed services and adverse childhood experiences. So we certainly train the people that are, the detectives at the police department and the employees from the health center and YWCA that are eligible to serve on the team. But we've done some additional training with all of the police so that, no, we haven't gone through all of them yet. We're working our way because it's 83 or something?
230.
230, all right. Dyslexia a little bit. So working our way, I think we've done 90 or so of the officers, so we're working our way. It's an intensive 4-hour training where they learn about trauma, they learn about vicarious trauma, and then their own trauma histories and how that might inform how they're working with the people that they're coming in contact with. So we want to extend that to the rest of the police department, fire department, and ambulance services. And of course, we're always thinking about if we continue to do these stronger collaborations and likely getting more referrals, let's make sure that we're working with service providers so that we know they have the capacity to actually take in the families. So we have 12-ish minutes, and we're happy to answer questions. So what questions do you have about what we talked about?